Hey, Haley, and I'm not sure who Jay is. Is that Joe? We'll keep it a mystery.
No, it's me. We're getting ready to start Divvy's third case though, so I might have to leave here in a little bit. Just a heads up.
Oh, got it. No worries. No worries. We've got. I'll wait a little bit longer. It's about 4:32. I'll give folks a couple more minutes. Jeff, do you think we should push this thing back to 5:30 from now on?
I mean, I feel like from at least I know Divvy typically operates on Wednesdays. It's pretty common he goes till 4:30, so I think it would be helpful. Yeah.
Okay. I think we'll do that. We went back and forth last year between 4:30 and 5:30, and like some of the people liked 4:30 so they could be done by 5:30 and get the evening back. Some people sort of said can't get out of the OR in time or can't get out of clinic in time.
Sure.
So, but really, I want to make sure that you and you in particular can make it onto these.
Yeah.
Because we're talking about content that's geared at the residents and our fellow, right? So, no sense in not having an audience when we do this. Right. So let me do this. I'm going to hang tight. I'm going to wait a few more minutes, and let me see how many folks sign in, and then we'll decide whether we move ahead today or if we. If you're short on time and if not a lot of folks are signing in, maybe we'll reschedule. So let's give it a couple more.
I'll send a message to the group WhatsApp to make sure everyone knows what's going on too.
Oh, perfect. Yeah, appreciate that, Hilly. It'll kind of be like that thing in school where, if the teacher didn't show up in time, you could leave. We'll do it that way, but let's see. Hey, Sri. You got another case, bud?
Yeah, the trauma case that came in on Monday.
Oh, the magic one. I've heard about it so many times.
Which with the T9 fracture?
All I heard is that it involved one of our neuro partners, and then it involves cardiology and some other stuff. And
yeah, it's been a kind of a train wreck trying to get this guy to go.
Sounds like it.
He's he's a train wreck.
Sometimes you have to take urgent cases and give everyone around you the impression that they're emergent to get people to make decisions faster,
Yeah. I mean, if he was this is the one guy with cardiac issues that I can't do anything about bradycardia and hypotension, but
yeah. Hey, I mentioned to Jeff real quick. Maybe we'll move these talks back from 4:30 to 5:30.
Yeah, that might help on OR days for sure.
Yeah, I think so. That's kind of what he was saying as well. And I don't want him to miss it. And I think maybe some of the residents might still be in clinic, and it just maybe 4:30 is too early for these things. I don't want to do them at night because I really want to make sure we keep the evening hours sacrosanct for family,
Yeah.
you know.
Last time, Haley, you know if the other residents are around? I think they all kind of signed on, trickled in a little bit by a little bit.
Yeah.
I just sent out a message on our residency WhatsApp, so we'll see who's available. But I think it is a fairly busy OR day as we get closer and closer to the end of the calendar year.
For sure.
Yeah.
For sure. All right, let me see. Like I said, I'll wait a couple more minutes. I'm happy to go ahead and go for it. If I want to respect you guys who signed on and are listening in. We've got a lot to cover, so it can get dense pretty quickly. I'd say 80% of what I'm going to tell you is fact and 20% is the opinion. And you'll probably remember the opinion more than the fact, but that's okay. That's usually the sign of a good talk. All right, so I'll go ahead and get started. And I think Sri and Jeff, if you guys have to jet out, just feel free, jet out, and we'll maybe look for a time closer to 5 or even 5:30 down the road.
I think there may have been a problem with the invite because I didn't get an invite. I just found out when Haley texted the group.
Oh, really? Okay. Looks like MK's on. That might be an issue, right? If we didn't get the invites out to everyone.
Peter,
It
have you
showed up
been
in my Outlook.
have you been checking your NM email and not your Northwestern email?
Yeah, so I guess it was probably sent to my Northwestern email, and when they did this switch, I only check my NM email now or something. So that's part of it.
They stopped forwarding the two last week, so that might be it.
That could be a problem. Haley, did you have one sent to your NM address or to your Northwestern address?
Just my NM and not my Northwestern.
Okay. All right. We might need to do some cleaning up on the email list. Well, listen, if we've got time, let's get going and we'll cover this topic because it is an important one. Give me a second to get my screen share going, and I'll do my best to get us done in time, by about 5:20 or so, and we can stop and ask questions along the way. It's a small enough group of us that there's no reason not to interrupt and make it more of a conversation than a pure didactic. Is that screen coming through?
It is.
Looks good.
Yep. All right, good. All right. So I know Dr. Sue talked to you guys last week. I think it was last week about cervical degenerative disease. This is sort of meant to be the complement of that of lumbar degenerative disease. And what we're going to go over are probably 3 things. One is just to talk a bit about lumbar degenerative disease, and let's make sure we all have a common language and a common understanding of what these pathologies are and what we're seeing. We're then going to walk through a strategy to sort of think about low back pain and radiculopathy or leg pain. And many of you guys in clinic will have seen us go through this thought process, but it helps to sometimes sit back and actually, spend more time than we do in the hustle and bustle of clinic to sort through all this. And then talk to you, and this is where the opinion part comes in, talk to you about what we think of as the key determinations of surgical decision-making when we're talking about lumbar degenerative disease. So I think disc problems, look, we're going into the holidays. You guys are going to be seeing family that you may or may not have seen in a long time, especially post-COVID. I guarantee you someone that you run across in the holidays is going to talk to you about their lower back. It's almost a guarantee. After they talk to you about their knee pain, they're going to probably talk to you about their lower back pain, right? And you'll hear this tossed around in family circles, amongst your friends, maybe even, and certainly amongst patients coming in. There's a lot of different words that people will describe their back problem with, right? They'll call it a bulging disc, slip disc, you name it. And there's probably a much longer list than this, but they'll almost always be thinking about or pointing to some component of low back pain, right? And somewhere along the way, there will be an imaging finding that defines it in one of these terms based upon sort of how the physician interprets the scans. And so what I want to accomplish with this talk is to give you guys some clarity, right? Look through some of the fuzziness around language and the uncertainty about what does it mean to have a bulge disc versus a protruded disc, and maybe seek some clarity in understanding the clinical implications and how that drives clinical treatment. So, disc degeneration does follow along this sort of spectrum or this continuum of grades, where you go from normal or very mild changes within the substance of the nucleus and annulus to then more and more severe annular disruptions, ultimately resulting in sort of disc mechanical problems as well as not just histologic problems where you have disc collapse. And really, I'm going to make the argument that that entire cascade of disc degeneration is really normal. And we probably shouldn't be calling it degenerative disc disease because it's not a disease, right? This is all very much normal. In a subset of patients, this may create symptoms, but by itself, I think we want to really move away from this concept of being a disease process and think of this as a normal process. And so, oftentimes when we have that discussion with patients, we get this question back, well, how can all these things be normal? Like bulges and dehydration and protrusions and annular tears. And all you've got to do is read a few different radiology reports to get pretty nervous pretty quickly if you're a patient. And oftentimes we then have to unpackage all this and describe it in simpler, maybe more common sense terminology. So I'll use, to that mind, I'll oftentimes try to bundle a lot of these concepts into concepts around arthritis or wear and tear, which probably rings true to our orthopedic background for many of us. And really, if you want to get philosophical about it, it's probably just life. It's like the normal progression of life over time. And how do we know this? Well, we know this from going way back, way back when MRI first came out, right? This was the first chance we really had with advanced imaging to look at soft tissues deep inside the body, right? We could look at X-rays, we could look at CT, but MRI was the first time to look at soft tissues. And what you found was a large amount of pathology being identified. And that large amount of pathology was driving a lot of treatment, even if maybe we didn't know if it correlated. So this was a study, Scott Bowden, who's the chair at Emory now, he did this study, I think, either early in his practice or even maybe as a resident, where he had done a prospective series of patients and found a few things, that these abnormal findings, disc herniation, stenosis, bulging disc, seems to correlate pretty well with age, such that if we look at the group of people in their between 40 to 60, about 45% of them will have some type of pathologic finding, okay? And if you bump that age bracket up to 60 to 80, right, about 80% of them will have some degree of pathologic finding. And the key thing here is that these are asymptomatic subjects, meaning, again, these are pain-free individuals. These are not people presenting with back pain. These are people who have no symptoms whatsoever. And this really, I think, this and studies like this, I think really drive our discussion at Northwestern with our patients about why we really pump the brakes on getting aggressive about MRI findings as it pertains to stenosis, disc generation, bulging discs, et cetera, in the absence of concordant symptoms. So this is really, really kind of probably landmark work that we need to keep in the back of our minds as we're seeing patients. In terms of what does cause degeneration, we talked about age. That's probably the primary factor. There probably are environmental factors. We know in for example, contact athletes, they will present with relatively advanced degenerative disease of their lumbar spine at a much younger age and probably to a much more severe level of involvement than their age-matched patients. Smoking, I think, if we look at the data on smoking, it's not level 1 evidence, and it may be a confounding factor, environmental factors, psychological factors, but smoking generally seems to be linked to, at least in my experience, earlier signs of disc wear or disc degeneration. We know there's a pretty strong genetic component to it as well. There have been, twin studies that have been done, but generally most of the reports of degenerative disc disease and genetic relationships are pretty limited, fairly limited to poor evidence. We did a study about 9 years ago, maybe, looking at the genealogic database in Utah. We had over 2 million people with many matched controls. And this was just looking at lumbar disc herniation, the data I'm showing here, but we also had this for, diagnostic codes for lumbar DDD as well. But if we just look at disc herniation and we look at how likely is it that if someone in your family has had a disc herniation, that a close family member is going to also have that similar type disc herniation? And what we found was a pretty strong relationship, so that risks are much, much higher in families within about 1 or 2 degrees of separation. So it's not uncommon that if we ask patients who are presenting to us with degenerative conditions, if this runs in their family, you could expect most of the time that they're going to acknowledge somebody relatively close to them has had a similar problem. Not always, but most of the time. So that's sort of some, I think, basic background on degeneration itself, right? Again, remember, it's normal. It's not a disease process in and of itself. But let's shift then to talk about the actual patient presentations. And when does a normal finding, if you will, become a pathologic or symptom producing finding? And so in that sense, I think what I tend to do in my practice, I will very quickly try to categorize patients as, are they back pain dominant patients or are they leg pain dominant patients? With the idea being that the underlying pathoanatomy that I care about is going to be different between back pain and leg pain, but also the surgical options I'm going to have, as well as non-surgical options, are going to be very different between these two categories. And so if we sort of say, listen, back pain isn't just about the disc, we have to keep in mind lots of other potential causes of back pain that exist. We know it's related to muscular weakness. We know it's related to an underlying arthritis. You have to think about the facet joints, the SI joint. You can think about folks who've had repetitive injuries. We see a lot of folks who are deconditioned. They live really sedentary lives, really sedentary jobs. They do this. They're in front of a computer all day, and that puts them out of shape, let alone the issues we talked about earlier around smoking and about genetics and about age. And then also keep in mind, a lot of individuals with back pain, and we don't know if it's a chicken or egg. We don't know which one comes first, but there's a high psychological component in terms of both anxiety and depression that are, very heavily linked with back pain. And we can't ignore that as well as we think about our patients. So when it comes to treatment of low back pain, which let's say we're thinking it's degenerative disc disease as the cause of low back pain, the real answer here is not a simple one, right? It's a heavy lift. It's multimodal, coordinated care. It involves physical therapy, exercise, lifestyle modifications. There's a lot that goes on, cognitive behavioral therapy. There's a lot that goes on into the treatment of low back pain. And I would say in general, for us as a group of surgeons, we need to be aware of this and we need to be guiding our patients down this path, right? And maybe not so much towards the surgical path over and over again. There are these other things out there, and the other list is super, super long. I mean, it used to be back in the day that every store at the mall was selling different back pain gadgets, right? Manipulations and traction. There's still massage. There are these inversion tables. Now it's like if you scroll Instagram and you stop and you look at a back pain issue, you'll see every back pain widget. You'll see every back pain brace. You'll see these bumps that you can sit on, all kinds of stuff that are all meant to and geared to help people with low back pain. And the honest answer here is when it comes to all of these different products and treatments that are out there, there's really no evidence to suggest that they help. Oftentimes the help is in the immediacy of treatment. So these are oftentimes easier things to do, faster things to try than that heavy lift of lifestyle and dietary changes and exercise and PT. And so oftentimes this is still where most people turn because it's the easiest way in and it takes the least amount of effort. But there's really no evidence to support it. And we got to remember that this is a massive, massive financial industry that's based on all of these treatment options, right? If you look at the chiropractic care that's provided, much of it is actually very good chiropractic care, but a lot of it is overdone, unnecessary care. And the amount of cost that drives makes our surgeries, pale in comparison, right? So just keep in mind that there's a lot going on there around back pain. And I think our job here is to give patients good guidance on where there is evidence to support treatment, where there's not strong evidence to support treatment, and where they need to be careful that they're not getting taken advantage of. guys here? Let's see. So what about lasers and stem cells? And gosh, the list keeps going. So these are super fringy ways of treating low back pain. We basically, I think our answer to patients is to stay away from all this. There's really nothing that's been proven in any of these brand new technologies to necessarily solve low back pain better than what we know works really well, which is the heavy lift. Again, these are all ways that people are thinking about new businesses or coming out with new products, but really, I think it's safe to say that these are sort of unproven. And when it comes to some of these treatments like stem cells, probably also even unsafe. And I think we need to guide patients away from it. So then this begs, I think, a really important question. And this is one where we generate usually some controversy amongst a group of spine surgeons, which is low back pain actually a surgical condition? Right? And I usually pause just to let you think about that one for a second. And I'm going to give you my opinion on that answer, but I think we'll get some conflicting opinions as we talk. And certainly as you'll see throughout your careers, there's still a lot of difference of opinion on this. So, when it comes to spinal fusion for low back pain, highly in the spotlight of the public, highly in the spotlight of media. This is an example of one of the articles that sort of comes out talking about how the evidence doesn't support fusion, and yet we see a massive amount of these procedures being done. Highly in the spotlight because of how this condition, low back pain, and the treatments offered like spinal fusion seem to put people down a spiral, continue them rather, down a spiral of back pain and chronic pain and opioid use. And I think the general public, the media, payers are all asking, really, where's the proof that this is a good idea? And I think we need to be asking those exact same questions. That really, is there really evidence that supports the use of it? So if we look at the evidence from a few years back, I haven't updated this year, but there's not much more convincing evidence that's come out. If we look at relatively well done studies, randomized controlled studies that are out there, most of these randomized studies are going to lean towards the idea that surgery is not beneficial compared to non-operative management. And these are just the RCTs. The number of other studies that have been done, and that's a hard study to do, to randomize someone to surgery or not. If we look at some of the other observational surgeries or observational studies that have been done, or retrospective studies or database studies that have been done, there's really not an overwhelming amount of evidence that says that surgery for low back pain really helps people, right? Whereas the opposite is true, is that you can see evidence to suggest higher pain, higher disability, and secondary impacts after spinal fusion surgery. And why is that? So why is it that we think we have a pathologic disease state, degenerative disc disease? We have a patient with back pain. We remove the disc, we fuse the segment, we take away the motion, and we don't see symptoms improve. And by the way, that holds true with disc replacement as well. We don't really see proven predictable results in terms of surgical management. And I think we have to step back and understand there's a ton of confounding factors in these patients, right? First of all, there's pathologic factors. So when you talk about 1 level versus 2 level versus 3 level disease, how do you figure out which level is really symptomatic? We think about the pain behavior patterns that many patients with chronic back pain bring in. When we think about the use of chronic narcotics, sometimes exaggerated pain symptoms, those sort of things. There are absolutely massive psychological factors at play as well that drive both negative and positive results. There are social factors that come into play, especially if you start thinking about litigation and secondary gain. And then there's probably a lot of limitation in our actual outcome measures that we use. We tend to report old outcome measures like ODI, for example, which have really high floor and really low ceiling effects. So you can't really measure the worst of the worst, nor can you measure the best of the best. And so you get this muddled view, or I should say you actually get a very narrowed down view of the population of patients that we're treating. And maybe the outcome measures don't allow us to effectively see the improvement that we think we're generating. So if there's all this uncertainty, why is it still being recommended at such a high rate? And again, probably after microdiscectomy and laminectomies, spinal fusion is probably the 3rd most common procedure. being done in the United States. And so again, we're looking at a situation where we've got principally, although we're all patient-centered, remember, let's be honest, it's still a surgeon-driven decision-making process, right? And there's a lot of confounders when it comes to decision-making that I think influence the decision to offer fusion to patients, right? And not all of these are sort of at fault, if you will, they're just human nature. So one is this idea of availability heuristic. So you're going to think about and remember the patients that have done well, and you'll judge your practice off of anecdotal results as opposed to looking to sort of larger bodies of evidence, which you feel like may not justify the procedures that you've been performing. There is this really strong concept called around bioplausibility. So there's this idea that it kind of makes sense that if my back hurts and I have a quote unquote bad disc, removing the disc should help me, right? That's not a very complicated line of thinking, even if it's not supported by the evidence. It's plausible, it's simple, it's easy to understand for both patients and for surgeons. And so again, that ease of understanding oftentimes leads down that path. There's absolutely a demand from patients. I think we see patients who are at their wits' end at the end of their rope, if you will, trying to find solutions for really bad back pain, and they're willing to try anything. And so I think that oftentimes leads down a line of thinking that is, well, if I don't do it, someone else will do it. So I should do it so that it's done really well. That's kind of a bit of a dangerous path to start going down. And I think it's one that you want to avoid. The other one is, well, if I don't do it, patients are going to complain and they're going to create a lot of hassle for me. And I said, okay, yeah, they do. That happens for sure. But still, it doesn't really mean we drive our surgical decision-making based purely upon patient demand. And then the last thing we cannot ignore are the financial incentives, right? So there is still a very, very strong incentive structure built in around providing surgical care versus providing organized, deliberately well thought out non-surgical care. And there's a very, very big difference, both in terms of financial incentive, time, everything. So there's a lot of things that drive the decision-making process towards surgical management, even in the absence of really strong evidence. And so the question oftentimes comes up and is, in the setting of back pain, can we find the ideal patient? And I don't know if Wellington's on right now. He usually is, but if he's not, he'll usually talk about like this, an ideal patient with the right pathologic or abnormality, the right amount of disability, enough but not too much, pain again, enough but not too much, social and psychological status that's sort of in that safe zone. And you're really kind of threading the needle, if you will, on all these dimensions. And I'm only showing 4 here because when you start to add more in PowerPoint, it gets to be a really big jumble and you can't tell what's what. So if you can imagine trying to thread the needle on all these factors and getting it right every time, that's what you're trying to do if you're trying to find the ideal patient for a lumbar fusion. So I think the questions you want to ask yourself when you're seeing a patient with low back pain, and I'm going to talk about back pain dominant symptoms. If they have a little bit of radicular symptoms, that they still fall in this bucket, right? The problem they're trying to solve is back pain. I think you should ask yourself 2 questions. One is, can we reliably find the right patient? So one-on-one, probably we can get pretty close. If you ask me to do it for a group of 1,000 patients, it gets really hard. If you ask me to do it for a pool of insured patients, that's about 300,000 in size, it gets almost impossible, right? Mathematically impossible to find that right patient. And then even if we find that right patient, can we reliably predict what their outcome is going to be? And my answer to that is that I don't think we can do either of those very effectively, at least currently. The time might come that we'll be able to harness some more data and we'll be able to look at sort of personalized predictors of good and bad results that we can provide a lot more clarity than we can right now. So my answer is usually no. And then the response that I'll get is, well, if you say no to everyone, you're gonna lose out on the opportunity to help a few people. You're gonna take the baby and throw it out with the bathwater. That's usually the retort that will come up in sort of conversations when we present this topic as debates at our national meetings. You're going to throw the baby out with the bathwater, and that's a real disservice to those patients who we could help. And I do agree, and I do feel for them. But again, if I would say, if you look a little closer, at that baby, you're going to start to find some issues that you'll need to resolve or come to terms with, right? So, maybe that baby isn't as cute and cuddly as you think. Maybe that baby has a really, really bad habit, right? Maybe they're smoking a pack, 2 packs a day. They're bringing their OxyContin with them and asking for a refill. It's a cute little baby, but gosh, that baby's a little chubby. Maybe it's on the heavy side of being overweight, or maybe it's even on the anorectic side of being really, really underweight and at risk for nutritional complications. Maybe that baby really expects to be completely normal at the end of the day and has completely unrealistic expectations. Maybe that baby was involved in a car accident at one point and their back is hurting and they've got a lawyer helping them out. And don't forget, the baby also rolled up with all of its emotional baggage at the same time. So I would just say, if you ever think you have that absolutely perfect patient, dig a little deeper, scratch the surface. And if you ask a few questions, you oftentimes will unmask, reasons to sort of stay away from surgical intervention. So that's my opinion part as it comes to low back pain. Why don't we stop real quick? There's enough of us on there to have at least a brief discussion before we shift into leg pain and sort of radicular pain. But Sri, I see that you're on. Hopefully you're still on. You're not scrubbed in yet. What do you think? What was your teaching as a resident? What do you bring to your clinic?
I like your analogy, and I think it fits. From the kind of like the surgical decision making, but basically we all want good outcomes. And the people that are out there kind of offering, solutions for back pain, I'm always like skeptical of the true outcomes. Obviously that there are the ones that do respond, but yeah, we don't have the diagnostic capability. And I do believe that back pain, is an issue. We just can't identify, like you said, the appropriate pain generator. I think one aspect of that is like, a dynamic component you can identify with pure back pain. I think I've seen a few people in clinic and I've kind of just been slow playing them, but I think that maybe a person who responds really well if they're back pain dominant and there's dynamic instability. I think that's a good indication. But yeah, for the most part, I'm on the same page. I think I would feel dissatisfied. The patient would feel dissatisfied if, you err on the wrong side and guess wrong. Yeah.
I think there's the diagnostic side for sure. And I like one of the things you mentioned, because I will ask this question, if folks are having, if what we know as disc mediated pain, it really should be pain that's worse with prolonged sitting. Generally gets better once they get up and move about a bit, although it can come back. And if they lay down and a lot of their pain goes away, their back pain goes away, that makes me think more about a dynamic issue or a mechanical issue. It's not a perfect question, but versus the patient who just has terrible back pain no matter what position they're in, right? I would agree that there's a dynamic component that you want to think about for sure in these patients.
Dr. Patel, I just want to go ahead.
No, I'll just throw one thought in there on that kind of line. I think like some of the research we're doing in the lab over at Jeff is like, are there biomarkers kind of that we can do that, will accurately, with high specificity kind of target, disc related pain. Then again, then the problem becomes like finding the right level. So,
yeah,
then there's also that issue, but, there's probably more work to be done kind of in that arena, but we're probably not close yet.
Peter, what were you going to say?
I was just going to kind of follow up just on like your physical exam in clinic. Like, what are you doing specifically? Like, obviously midline pain, paraspinal muscle tenderness, SI joint pain. Like, what are you doing specifically to determine whether it's maybe more muscular or not? And then in terms of working it up, right? So they have like midline axial back pain and you can like pinpoint a spot. Is it like, okay, advanced imaging, or is it an injection? What do you think?
Yeah, so I'll give you the answer from a surgical lens, which is a little bit different than sort of taking care of patients with lower back pain in a primary care setting, if that's a fair way to answer that. So in a surgical lens, I probably get more of my information from the history than I do from the exam. And what I use the exam for, obviously, is to look for any neurological involvement that might or might not be there. I also look to see, could this be their hips? So I'll always examine their hip joint. It may or may not be a hip pain that they're presenting with. Obviously, low back pain is different, but if they're having a lot of buttock pain, I'll examine their hip. I'll try to see how their pain behaviors are, how they act when they're being distracted versus when they're being examined, right? Because sometimes if you're in a conversation with people, you may see them just naturally sitting very comfortably, but then when you go to examine them, you can see them kind of tighten up or lock up. And to me, that's a sign at least of a fair amount of sort of like fear, right? And fear behaviors coming to the table. And then just looking for areas of tenderness. If they're jumping off the table every time you lay a hand on their back, to me, that's sort of a negative predictive factor, right? I think that's a bad sign in terms of identifying isolated disease that you're going to help. And then the last point you mentioned, Peter, is just trying to differentiate low back from SI joint pain. I do believe that people have low back pain mechanical, and I do believe that there's mechanical SI joint pain. They're just really difficult to differentiate. But an exam is one of those components that helps you at least get to maybe, if the low back is a zip code, you want to get down to like, okay, which block is this on? Like, am I narrowing down the location of the problem by an exam?
Thank you.
Yeah. Other thoughts? These are all folks we're going to be seeing. These are all patients we're going to be treating a lot of. And so I think you want to have your thoughts on this fairly clear. And I think you want to have at least a workup in place in your mind, thinking about, and we're going to talk about diagnostic imaging in a minute here, but thinking about how you evaluate these patients. And I would strongly encourage you. I think for me personally in my career, it's really helped me in terms of getting more reliable outcomes, more predictable surgical outcomes, finding ways to differentiate my primary low back pain patients from my patients with, primary leg symptoms, and trying to focus my care much more on this population, which we're going to spend the rest of the maybe 20 minutes or so talking about, as opposed to the first group of patients. The one thing I will finish by saying is that Sri had mentioned this, we used to do discograms on patients with back pain, trying to identify, which disc was the painful one. Found out not a very specific test, sensitive, but not specific to a singular disc. There are a couple of studies that have shown biomarkers, both in the peripheral blood. I think, Sri, you mentioned in the disc. There are a couple of companies out there that are offering technologies to look at sort of almost like a chemical histogram of the disc itself based on MRI properties. So there's definitely a lot more work being done to try to elucidate, if you will, the chemistry and the structure of the disc in vivo. It's just all super early, right? And the amount of clinical data that's going to support it, unfortunately, is going to be pretty limited for a while. So just unfortunately, the biggest problem that we have when it comes to spine problems is back pain. The thing that we have the least reliable and the least clarity on as far as surgical treatment is back pain. So there's this mismatch that we're living in. That's an issue we're living with every day as spine specialists here. So let's move on, if we're okay, to talking about leg pain. This is a little bit of a cleaner, clearer conversation. Again, patients will oftentimes present with pain from the lower back down the leg in a varying pattern. I think in an ideal world, they would show up. Let's see, for example, they have a disc herniation with fairly severe sharp pain, and it would radiate and radiates past their knee, and it's associated with weakness and numbness. And on your in training and on your boards, it'll lay it out as a really smooth, very nice dermatomal pattern, whether it be S1, L5, L4, etc. So it's worth knowing the dermatomal and myotomal patterns. In the real world, the discs will generally match these, although there's always a little bit of give, right? So it's not uncommon to see an S1 root being compressed, and yet the L5 root being compressed, and yet it's somehow looking a little bit like the L4 or looking a little bit like the S1 nerve roots. There's always a little bit of overlap, but listen for and look for those dominant dermatomal patterns. Sorry, guys, I'm getting some glitching here. So on exam for these patients, again, we're going through a motor and sensory exam. We're looking for reflexes, which are typically normal or absent in the setting of a disc herniation. But I think the primary sort of diagnostic finding that sort of maybe guides you towards, I should say the primary exam finding that would drive you towards a diagnosis of disc herniation is a straight leg raise. And that's either a seated slump test, like it's diagrammed on the right side, or a flat straight leg raise where you get symptoms, recurrence of not back pain, but leg pain with an attempted straight leg raise. Sometimes you'll see it on the ipsilateral side. Sometimes if the disc is big enough or in the right enough location, you'll actually get it with the contralateral leg, where you raise the asymptomatic leg and it actually sets off the symptomatic leg. Keep in mind that there are other things that cause pain in the leg. Hip and knee pathology can cause pain that might overlap with or get confused with a lumbar radiculopathy. Peripheral vascular disease, a really common one. Peripheral neuropathy. Those are probably the top three in my mind that I'm always thinking about or considering in these patients. And then there's the other category that we can always sort of include in the differential. Diagnostic tests for folks with disc herniations. I think in the ideal state, like again, in a vacuum, you would start with X-rays, treat these individuals, and then later on obtain MRIs if needed. And I think certainly there are many health systems out there that drive that sort of systematic management of patients in the primary care setting. In our world, what we're really looking at is getting MRIs for these individuals once we've seen them, examine them. And if honestly, if they don't have a neurological deficit, you can manage them for a while without an MRI. You should be able to trust the history and your examination to drive initial non-surgical treatment. But when do we get an MRI? I would argue that it's really only needed if we're dealing with one of the following situations. One is if there's substantial weakness or numbness. And substantial is a soft term, but in my mind, if there's a grade 4 out of 5 or less strength in the leg, and it's really a weakness, it's not just pain-mediated weakness, or if there's numbness and paresthesias in the leg, I think it's warranted to get an MRI scan. If there's a history, if a patient has a history of infection or a patient has a history of cancer, in my practice, I automatically get MRIs in those individuals. Folks who have failed the initial round of conservative treatment, in my mind, that's at least 4 weeks, sometimes up to 6 weeks of treatment. And then when it comes time for surgical planning, you might need to get an MRI or an updated MRI in those settings. If we think about the MRI findings and when we talk about disc herniations, we want to first start and think about where is this disc located? And then we'll get to, does this disc correlate with what the patient's telling me is going on? So if we think about the different zones, let's think about central discs, okay, in this sort of central region here, as demonstrated in this image. We see that central disc could affect the nerve roots, on either side, or it might be totally asymptomatic. You've got the more common posterior lateral herniations where it's off towards one side, usually sneaking out and around the PLL. Those discs can also be classified based on where they go. Most discs tend to stay at the level of the disc or drop, and they'll go caudal, probably because of gravity. But occasionally they can extrude dorsally as well. Disc herniations can be contained, meaning subligamentous, submembranous. They can be extruded, they can be sequestered, or they can even be, frankly, migrated in a distal site. So all those are different terminologies that you'll use to describe, if you will, the physical location of a disc herniation. And so if we look at a patient like this who might show up with low back pain and a left-sided radiculopathy, we would say, okay, here's somebody who has a central disc with compression over here on the left side in that lateral recess or subarticular zone. But really the question we need to be asking is one of correlation. Does this finding match the symptoms that the patient's bringing to the table? And the reason that's important is that disc herniations, while present, don't always need surgery. Most of the time, these will resorb and resolve on their own. And there's actually reasonably good data that says that there'll be both. There's actually very good data that says with non-operative management, you'll see a great improvement in pain, right? Really pretty impressive numbers that non-surgical management for disc herniations works. And there's some data that says that a gradual resorption of the disc can be expected. So patients will often ask, well, if I've got a disc herniation, doesn't it need to come out? And I think it's a pretty fair answer to tell them that we'll watch their pain, we'll watch their symptoms. And if their symptoms go away, you'd expect and anticipate the disc to gradually go away as well. And so when we talk about surgical treatment of disc herniations, just a quick sidetrack, mostly just to geek out on this for a second, can we ask ourselves a question of why does a disc herniation hurt? Who can I ask? Maybe I'll ask Haley, just because she's our chief resident right now. Haley, why does a disc herniation hurt? What do you think?
Do you get like nerve root edema?
Okay, so edema, maybe like
Inflammation.
pressure.
Then,
so edema, pressure, inflammation, right? Right.
And then like the inflammatory cytokines that are associated with disc herniation are also pain generators.
Absolutely. So you hit on the big ones already, right? So there's this concept of, there's definitely the first answer most people give is, well, the disc is pushing on the nerve, right? So you think about mechanical compression. And with mechanical compression, you'll see nerve fibers around the dura and even in the endoneurium that may be responding to compression. You may get local ischemia even, or nutritional changes that causes pain. But again, let's go back to that Bowden study that we talked about earlier, where maybe about 1/3 of these patients actually had no symptoms whatsoever. So compression alone obviously can't be the answer if people are walking around with disc herniations and not having symptoms. I think you're right. You spot on. Haley talked about other factors, okay, that could cause the disc to hurt. So this is an old study from the 1950s where they took patients who had disc herniations, they removed the disc, they then tugged on the nerve root afterwards and would ask patients if it hurt or not. And not surprisingly, it would hurt quite a bit. They did the same thing on a normal root. So they then took a normal nerve root, put a suture around it, tugged on it, and saw no pain whatsoever, right? So there's something that happens to the nerve because of that herniation that makes it symptomatic beyond just compression. And that's when we start to think about things like inflammation. Haley, you mentioned spot on cytokine releases or inflammatory mediator releases from the disc itself. And there may even be some concepts around structural changes within the nerve itself, within the axon and the myelin sheath around the nerve, that allows the nerve to be more excitable, right? And so we have to keep these factors in mind, because when we think about treatment, it offers us a whole nother potential line of therapeutic management beyond just removing the disc, right? Structurally. It also tells us that in patients who we remove the disc on, these other factors might still be in play and might explain why we continue to see neurological symptoms, pain in particular, even after a successful discectomy. So really important to understand that what we're looking at is both a mechanical issue, and then I'm going to label it or bucket it into a category of biologic, and that includes inflammation, sensitization, excitability. So remember, there's two different pathologic processes going on, and that drives our initial treatment. So non-surgical management in particular, NSAIDs, oral steroids, therapy, gabapentin, Lyrica, these neural stabilizing medications have kind of become first-line treatment. Epidural injections, they're there as an option as well, as sort of that next level or second tier of treatment. The evidence on epidural injections for disc herniations is relatively good. Not great, but relatively good. That a number of individuals who have epidurals can probably avoid surgical management. I will tell you, this is not level 1 evidence, but it certainly is a sign that this is a reasonable option for patients with symptomatic disc herniations. And surgical indications in this setting really involve severe weakness. So somebody presenting with, in my practice, less than a grade 3 out of 5 strength, so a grade 0, 1, or 2. I'm generally thinking about more aggressive or earlier surgical intervention. somebody who presents with progression of disease, progression of symptoms in particular, and progressive weakness more specifically. Folks with intractable pain, it's pretty rare, but it does happen at times that you'll find individuals with disc herniations who are just completely, utterly floored by the disc herniation. They can't walk, they get hot, they go to the emergency room, they get hospitalized, and they have intractable pain. That's a pretty good indication for acute surgical intervention. And then the standard kind of failure of non-surgical care, which we think of as generally being present for at least a period of about 6 weeks. So what's our comparative data then? If we've talked about the pathophysiology of disc herniations, how it presents clinically, how we might treat it non-surgically, how we might treat it surgically, what's the comparative data? So there's a couple of studies to talk about. One was a study from JBJS about 2004, about 170 patients with disc herniations, 6 weeks of non-operative management. And this is what they had documented in that study, was that injection success was about 40 to 50% success rates. Surgical management was a much, much higher success rate, close to 90 to 98% of patients. They showed a quicker resolution of symptoms, and that folks who had an injection and ultimately had surgery still did well. So the epidural wasn't necessarily a diminishing impact on surgical results. So really advocating for a really strong incremental therapeutic benefit to surgical management. So the next big study, and this is a study that is still worth knowing, and it is definitely ripe for the boards and ripe for the in-training, which is the SPORT study for disc herniations. So this was a multi-center study, about 500 patients randomized. I'm going to come back to that in a second, but randomized to either surgical management or non-surgical management of symptomatic disc herniations. They had some pretty good outcome measures, SF-36, physical function. They used the ODI like everyone did back in the day. So it's a little bit limited there. But what they basically found, the headline of this article in JAMA, was that there was no statistical difference at 6 weeks, 3 months, 6 months, 1 year, 2 years. So when this study was released, the discussion point really became, wow, disc herniations really don't need surgery, in the same vein that we talk about folks with, let's say, knee osteoarthritis having knee scopes, right? They really don't, that it doesn't provide incremental benefit. And that's pretty much in stark contrast to the data that came before it. And honestly, a lot of our experience as surgeons. So how do we come to terms with what we're seeing here from the study? And it really comes down to, at least for the SPORT study, a real limitation, which is that of crossover. And so whenever you're looking at RCTs, you want to really get an idea of how much crossover was there in the groups. So if you started out in the non-operative group, about 30% crossed over. In the operative group, about 50% crossed over within the first 3 months. And oftentimes these studies from a methodologic standpoint are presented as intent to treat. So that if you're randomized in the surgical group, you're treated like a surgical patient, even if you never had surgery. And if you're randomized to the non-surgical group, you're treated like you never had surgery, even if you had surgery. So it really muddles it when you've got all of this crossover. So then the subsequent articles talk about as treated results. So rather than how you were randomized, how were you actually treated? And then what did your results look like? And in that setting, we saw pretty consistently better results with surgical management. The other arm of SPORT, and then we'll wrap things up here, is their observational cohort. So these are patients who did not want to be randomized, but still were willing to be part of the trial. A lot of patients, right? 743, a majority of them opted for surgical management. Remember, these are being recruited generally out of a surgical practice. So most people opted for surgery, but about 215 of them opted for non-surgical management, same primary measures. And what we saw from this observational cohort was that consistently across pain, function, and ODI, surgery outperforms non-surgical management, both statistically and clinically, in terms of meeting sort of accepted MCID numbers for each of these factors. So we then sit back and look at the aggregated view of SPORT, observational and as treated, and say, listen, in this setting, surgical management works much better than non-surgical management. With one caveat, look at those orange lines, right? Non-surgical management works. People do get better. So this isn't an all or nothing scenario, but it's certainly a situation where we can safely tell patients who have gone through appropriate non-operative management, if given the choice between surgery and continuing to ride this out, they're much more likely to get better relief of pain, better improvement in function with surgery than, with continuing to wait this out. So that's my takeaway, I think, for disc herniations. Remember to think about the location of the disc, make sure it correlates with disease pathology, understand that surgery is an effective, safe option with a quicker response to treatment, but that trying non-surgical care is totally safe. It does work. It does not risk permanent impairment, and patients can switch over into the surgical arm of care, or surgical treatment, I should say, without a real big detriment to their long-run health. So start with the non-surgical side. Once you've hit a time frame, you pivot over and give patients a lot of good reassuring information that the data, the evidence in this circumstance, unlike low back pain, is actually quite favorable for surgical management. So I'm going to stop there because we're already at close to 5:30, and maybe another time we'll cover lumbar spinal stenosis. But again, we have a couple minutes. Happy to answer questions, thoughts, anything that's on everyone's minds about, when it comes to disc herniations and how that relates to the spectrum of degeneration.
Thanks for that talk, Dr. Patel. That was great. Just a quick question. So what do you do with a patient that comes in, has like 2 weeks of severe pain, but no weakness, and like they're unable to work and they're asking for surgery? Do you sort of make them do this full 6 weeks, or if they're asking for surgery, is that someone that it's acceptable to offer them at that point?
Yeah, I think I'm always a little worried when people are asking for surgery, Joe. I get it. But sometimes if the pain is that bad and they're totally laid up, they can't work, they can't function, they're either not willing, or they've already tried, a course of oral steroids and an epidural. We'll try to fast track all that non-surgical care, maybe speed it up a little bit in folks who are really having that much pain. But if they've done those things and they're still just miserable in pain and non-functional, I think it's totally reasonable to take the disc herniation out, right? It's totally reasonable to offer them surgery early on, as long as you have that clear conversation with them that they understand, listen, if you could wait this out, even another 2 to 4 weeks, you've got a really good chance of this going away, right? Pain is a really big driver. And so you hate the idea of leaving somebody in terrible pain if nothing else is working. The other interesting component is, and I think it looks like Dr. Divvy had to jump off, but is the patient who has had resolution of their pain, but maybe still has weakness, and that's probably the more common situation, where someone will come in, they had terrible pain, their pain within maybe a 2-week to 4-week window is substantially better, but they still have a little bit of weakness, right? What do you do in that circumstance? And that oftentimes is the tougher conversation. My answer to that usually is, it depends. It depends on how severe their weakness is, right? If it's a pretty dense weakness, I'd think about taking them to the OR. Maybe if it's a pretty mild weakness, we'll see if they can ride it out and wait it out a little bit longer.
What do you think about so physical therapy, right, for disc herniation? Is it more of just a time thing and waiting it out, or like therapy, general spine health, is that helping the symptoms from the disc herniation, or what do you think?
Well, so what the literature would say is that it does do something, that there's a therapeutic benefit to therapy, right? To physical therapy. I sometimes think in some patients, we are literally buying time to let the acute inflammatory cascade burn itself out. I do think there's a benefit to therapy in terms of getting people back on their feet, getting them mobile, getting them active again, getting them to trust their back a little bit more. So there is benefit to therapy, but I don't know that the physical therapy by itself is what stops the inflammatory cascade. If we had some physical therapists on the line, I'm sure they would disagree.
All right, thanks. Yeah, I know we always, a lot of times we recommend therapy to people, and then I just had a patient one time ask me like, what specifically is therapy doing to help my disc?
Exactly.
then
Exactly.
I
And what
thought
I tell
about
them
it.
when I get asked that question, I tell them, listen, it's not going to take the disc away, right? It's not going to necessarily help with the herniation itself. That's where the medications or the injection will help the underlying pathologic process. But I look at therapy as a way to get people back to their day-to-day life. Right? Because
All right,
most
thank
people
you.
coming in with pretty acute radiculopathies, their whole everything's off. Their walking's off, their balance is off, their gait's off. They're moving their backs very unnaturally. They have like no faith, no trust in their back. There's a lot of stuff that's going on that I think therapy does help with, actually, quite a bit.
All right. Thanks for giving this talk. Appreciate it.
Yeah, no problem. I think we'll send an email out. I'll talk to Freddie. We'll plan on moving the time back maybe to about 5:30. And I'll double check that we've got all the right emails with folks so that we make sure we get people sort of signed in at least.
Yeah, that'd be perfect. I think we ran into like, there's this beer and bones thing that was also happening with trauma reps or something. So,
okay.
So that might have been also part of what's going on, but yes.
Got it. Okay.
The email thing should be something we could correct with Freddie.
Yeah. I think if there's, and I think maybe I'll ask you and Joe and whoever, any of the other residents, if there is a conflict like that you guys are seeing,
yeah,
let us know. I don't want there to have to be a choice, between one or the other. Unfortunately, like beer's going to win over a talk about low back pain any day of the week. But we can either move our time around, move it up a day, back a day so that it's not a conflict. Or we'll find a way to bring a keg next time and, make it a kegger, and we'll try to outdo the trauma guys.
Sounds like a plan.
Okay. So just communicate. Let me know, guys, if you're seeing a conflict that's coming up.
Thanks so much.
Okay. All right, everybody.
Thanks, Dr. Patel.
Hey, thanks, MK. Everybody have a good holiday if I don't see you in person.
You too.